Welcome, everyone. We're glad to have you here to our Tethered Cord Support Alliance April webinar with Dr. Holly Gilmer. Thank you, Dr. Gilmer, for being here. I'm Rebecca Smith, and this is also Melanie Ramsey. She's the Vice President on our Board of Directors, here joining us today and helping with technology also. She'll also be running our question and answer session. So just before we get started with Dr. Gilmer's presentation, I just want to introduce you really quick to the Tethered Cord Support Alliance. We're a 501c3 nonprofit organization that was started back in 2024 based on what had become a desperate need for more information and support for people who have been touched by tethered cord syndrome. So our mission is simply to improve medical care and quality of life for everyone with tethered cord syndrome. And some of the things that we are doing to accomplish this includes several programs that I just want to briefly touch on. First of all, our webinars, which thank you for supporting this and being here tonight. We're doing a webinar at least once a quarter. Sometimes there'll be more often with experts in the field who have graciously volunteered to share their knowledge with us so that we can get that high quality information out to our community. These webinars are recorded and we'll make them available at tetheredcord.com on our website and also our YouTube channel. So you can view them there. You can also view past webinars, and this one will be available within about 48 hours of when it ends. We are recording this session tonight. We also have several other exciting resources that are coming out regularly. We have some physical therapy resources that were just published this last month, resources for providers and also for patients. And you can find those on our website also. But please, I encourage you to sign up for the TCSA newsletter so that you can get updates about our events and resources as they're becoming available. The next webinar is going to be July 14th. We're going to be talking specifically about physical therapy, and we have an amazing panel of 4 different physical therapists who will join us for that. The next program I just want to touch on briefly is our one-on-one peer support program. This program allows us to connect people who are either new to tethered cord or just looking for help as they're navigating the journey, because as we all know, it can be long and complicated. So these are experienced peer support agents who've been trained and are ready to meet with you one-on-one and help you navigate that journey. So if you're interested in receiving support through this program, you can go ahead and fill out the form that Melanie's dropping in the chat now for that, and we will hook you up. Also, we have weekly Tethered Tuesdays virtual support groups that are hosted by Melanie Ramsey for the adult groups and myself for the pediatric groups on the 1st and 3rd Tuesdays of the month. They're adult groups, and it's a fun time, I hear. A good mix of people that can offer, information and experience, and just to meet other people who are going through the same thing. Everyone's welcome to come to those. The 2nd Tuesday of the month, we meet with parents and caregivers of children. And then on the 4th Tuesdays, and this one is objectively the most fun, I think, is when the kids can get together and just talk to people who are their own age, going through the same thing, and build connections. So please join us for those if you're interested every Tuesday. And then we can't do this without our volunteers. Our organization is 100% volunteer run. So everyone who's helping us out here is volunteering their time. If you're interested in helping, or if you have a skill that maybe you'd like to contribute, we would love to hear from you. You can fill out this volunteer form, and we would love to have you be a part of our team. All right, so we also would like to hear who you guys are. Melanie has a poll, if you can throw that up. Thanks, Melanie. Just we want to know if you're a patient, caregiver, parent, a clinician, or if you're just looking for more information and don't fit into any of those categories, you can select the last one there.
Nice. Yeah, a mix. Rebecca, just one note here. Our chat is disabled. Someone let me know. I'm working on
Oh,
it in the back end, but I am aware that for participants, chat is disabled. Give me a second and I'm going to figure it out, but we are aware. Thank you. I'm going to end the poll now. Thanks for weighing in, everyone.
okay. All right, thanks. So let's go ahead and move on to the main reason I know everybody showed up tonight. Dr. Holly Gilmer. Dr. Gilmer is a professor of neurosurgery at Wayne State University and is the chief of pediatric neurosurgery at Henry Ford St. John Hospital and Medical Center. She is a past director of the Board of American Association of Neurological Surgeons. She has served on the executive committee of the Congress of Neurological Surgeons, AANS CNS Joint Section on Spine and Peripheral Nerve, and the Council of State Neurosurgical Societies, the Board of Directors of the Wayne County Medical Society, and has been vice chair of the CNS Education Committee. She is past president of Women in Neurosurgery, the Peripheral Nerve Task Force, and the Michigan Association of Neurological Surgeons. She was appointed by Governor Gretchen Whitmer to the Michigan State Board of Medicine in 2019 and was elected chair of the board from 2023 to 2025. She also currently serves on the scientific and advisory board of the Bobby Jones Chiari and the Syringomyelia Foundation. Dr. Gilmer graduated cum laude from Harvard University and received her medical degree from the University of Michigan. She then completed residency in neurosurgery at the University of California, Davis Medical Center, followed by fellowships in peripheral nerve surgery at Louisiana State University Medical Center and pediatric neurosurgery at Children's Hospital of Michigan, Detroit Medical Center. She is board certified by the American Board of Neurological Surgery and the American Board of Pediatric Neurological Surgery. Dr. Gilmer's research and clinical specialties include Chiari malformations, dysraphism, hydrocephalus, neuro-oncology, peripheral nerve surgery, and craniofacial reconstruction. She's given over 90 lectures nationally and internationally and is a regular reviewer for neurosurgery, operative neurosurgery, world neurosurgery, child's nervous system, and the Journal of the National Medical Association. We're so grateful to have you here, Dr. Gilmer, tonight. Thank you.
Thank you for your very kind introduction. I will share my screen and I guess the poll is up.
Yeah.
Okay.
Should be done.
So,
You can exit out. Sorry about that if that popped up again.
no, it was good. Okay, so thank you all for attending. Thank you for your interest in tethered spinal cord and in our patients with this broad array of manifestations of this problem. I'm going to talk about subtle signs of spinal cord tethering. Okay. So I know a lot of you have seen MRIs of patients with tethered spinal cord. And this is kind of the traditional um, view of tethered spinal cord from a radiologist standpoint, or, most physicians. The spinal cord here, instead of ending around T12 to L2, the top of L2, it extends all the way down to L4 and or the fourth lumbar vertebrae. And this bright signal here is lipoma. So this is a transitional spinal cord lipoma with a tethering of the spinal cord down around L4-5. And if we look at the axials or the cross-section view, you see the spinal cord is stuck in this fat here. Lipoma is a benign fatty tumor. And so very clearly, tethered, nobody would dispute that. Sometimes it's a little more subtle. There is no big giant lipoma down towards the sacrum. Sometimes and I want you to remember these characteristics, so this will come up frequently. When you look at the top of the spinal column, in the thoracic spine, the spinal cord is just a little more to the front, and it's just much more to the back, down low, as if it's being yanked straight. So it doesn't follow the normal curve of the spinal canal like this. So this is suggestive of a tethered cord. And when we look at the cross section or the axial view, then we see the tip of the spinal cord, which is the conus, is sitting to the back of the canal. It's not sitting in the center with the nerves around it. So together with clinical symptoms and signs, this would be very suggestive of a tethered spinal cord. This is another example of the same thing. More anterior or more towards the front, up high, more towards the back, down low, as if it's being pulled straight, like a guitar string, instead of draping along the curve of the spine. And then again, as we look at the spinal cord, as we look at the spinal cord here, the end of the spinal cord, the conus, then we see it's pulled to the back. So why do we see, what is tethered spinal cord? Why does it happen? I know you've heard about some of that from my the previous lectures who've done this program. But it was first described in 1953 by Dr. Garceau, and it was just kind of a cord traction phenomenon that he had observed. And it was initially thought to be due to a severe scoliosis. Later, he described that there were longitudinal stresses within the spinal cord that then caused abnormal tissue metabolism, which then led to neurological deficit. And that concept, even in the 50s, turned out to be true. Untethering of the patient that he described resulted in neurological improvement. Harold Hoffman, Bruce Humphreys, or Bruce Hoffman, and Robin Humphreys up in Toronto, the Toronto group, were the first to coin the term tethered spinal cord. And they actually described tethered spinal cord originally as a tight, fatty phylum. Remember that as well, because we know that is what we think of when we think of a subtle tethered cord or the type of tethered cord that in which the MRI might be read as normal. But that actually was the original description of a tethered spinal cord in 1976. Then Shoki Yamada's group at Loma Linda University in Southern California further expanded the term to include spinal cords that were tethered to bony spicules that were stuck in the scar from the closure of an open spina bifida defect. Patients who had tumors or cysts that were tethering the spinal cord. And essentially, by the early to mid 80s, it was understood that anything within the spinal cord or the spinal cord phylum, the end of the spinal cord, after all the nerves have come off, if it's not filar tissue, then it's not elastic, and it is by definition tethered. Now, that doesn't mean that everyone who has an abnormality of the conus or the phylum has to undergo a spinal cord untethering. But, it's worth investigating. It's worth, taking a careful history and examination and a workup. So after that, in the early 2000s, A lot of papers came out, confirming essentially that releasing a tethered spinal cord does result in, improvement. And in these papers, particularly the one by Nate Selden, he's at Oregon State University now, uh, up to 70% of the MRIs had been read as normal. And they showed that most of those kids, if they had clinical symptoms of tethering, still improved from untethering. So between the 80s and the early 2000s, untethering for subtle tethered cord, tight phylum, fatty phylum was, standard and understood. Um, Further papers, and this one by was a survey of the American Society for Pediatric Neurosurgery, again showing that this was pretty accepted. So what do we see? How do we diagnose a tethered spinal cord? Symptoms it depends on the age of the child or adult, but symptoms may include lower extremity weakness, atrophy of the muscles, asymmetry, one leg shorter than the other, a leg length discrepancy, a difference in the girth between the legs and feet. Sometimes someone will describe that they always had to get different size shoes, a change in the gait, particularly with growth spurts, abnormal walking, a baby that was walking and then wants to crawl, doesn't want to crawl, doesn't want to sit anymore, may have a tethered cord. Sensory deficits may be appreciated in older children or adults. Patients can be hyporeflexic or hyperreflexic, and they can, in the extremities, have increased or decreased tone. The least common denominator really for a tethered cord is bowel and bladder dysfunction. All of the patients at least have, kind of at least mild constipation, and either urinary urgency or frequency. Sometimes the opposite, sometimes an increased bladder capacity and kind of an insensate bladder, which of course will lead to frequent bladder infections. A change in urodynamics. So if you're following someone that you're not sure is very symptomatic from tethered spinal cord, and you're following them by watching their urodynamics, you have a baseline study. If there's a change in the urodynamics, that can indicate worsening tethering. Okay. So neurocutaneous signs, things that we see on the patients. This is a newborn who was born with an open spinabifida defect. And, I close this. This is not an open, it's not a wound. It's not blood or anything. This is actually the spinal cord that's open like a tulip. And it never closed. And so in surgery, we have to close it, roll it up into a tube, and then bring the skin, the surrounding skin and tissue here around over that to close it. But I show this slide not to show this, but to show this tuft of hair. This is a sign that she was tethered here as well. So anything in the midline on the back can be a sign of a tethered spinal cord. She had these club feet, which, we can see foot deformities, hammer toes, high arches. If a child had a spinal cord untethering and the feet kind of straightened out, they will still have high arches, but if they had hammer toes and then they straightened out after untethering, if they start very subtly drawing up again, that can be a sign of retethering. And that's one, reason that it's so important to bring children to the neurosurgeon once a year until they really finish growing, about 18 years old, because the signs can be so subtle and so gradual that it takes kind of seeing them some time apart to really notice that, maybe there's a difference. Now, this child I show because the traditional teaching was that the sign on the back indicated the site of the tethering, and that anything that is below the end of the spinal cord cannot be related to tethering, right? It's just cosmetic, it's just there. A sacral pit, a dimple, something like that. The spinal cord ends, or the spinal canal, the dura, ends at about S2, S1, S2. And this baby, with this tail, as you see, was at actually S4. But he had an underlying tethered cord, and which I operated on last week. And I also was excising this and found that there was a track. When I tugged on it after I had his back open for the spinal cord untethering, the dura moved at the higher exposure. So then I was able to identify that it tracked all the way down from where his spinal cord was tethered to the tip of his coccyx. So literally anything, tufts of hair, dimples, sinus tract, hemangiomas, Mongol spots, which are kind of dark bluish spots on the skin. If they're in the midline, they can indicate a tethered cord. They can be very, very subtle. This was just kind of a soft little fluctuant area, bone defect in a newborn that the neonatal ICU actually picked up when he was born. And sure enough, he did have a tethered cord underlying. And then, of course, sometimes it's a little more obvious. Mhm. This little girl just had some little freckling here. So anything like that is worth imaging and looking further. And then this is another example of the classic radiographic findings with a low-lying conus lipoma. Now, we talk about occult dysraphism, occult tether cord. This qualifies as an occult tether cord too, occult spinabifida. It's the difference between open, the baby that I showed earlier who was born with the spinal cord open, and uh, uh, dysraphism of the spinal cord, tethering of the spinal cord lipomas, tumors, tethering even just a thickened phylum or a tight phylum without necessarily any external signs indicating that there's a tethered cord. Okay, so our subtle cord can be, atypical. But what you notice about this one, in addition to the cord being more anterior at up high, more posterior down low, like it's being pulled straight, is how thick it is here. So the spinal cord ends here, let's see, 5, 4, 3, 2. Spinal cord ends at L2, 3, which is a little low lying. But below that, it's very thick. And then you can kind of see the nerves here, almost like hairs. The phylum should typically be thinner than the nerves. And when it's very thick like this, almost a third the size of the spinal cord itself, then that's suspicious. And, the axial shows that as well, how much bigger the phylum is than the nerves in this patient, as well as pulled to the back of the dural sac. So this is a fatty phylum or a thickened phylum. Yeah. So I'll show this case with a very atypical presentation. This was a 15-year-old boy who had always been kind of sickly, had chronic fatigue. He was found to have central sleep apnea, and he was first referred to me as a possible Chiari malformation. For those of you who might not know about Chiari, it's when part of the cerebellum goes down into the spine. And that causes a blockage of fluid flow between the brain and the spine and problems from that. It goes along with tethered cord about 20% of the time. So he was being sent to me for suspicion of that because of the sleep apnea. And it turned out he had insomnia at night because of that, hypersomnia during the day. So, of course, because he wasn't getting good sleep, he had chronic fatigue. Chronic fatigue and sleep deprivation affect the immune system. So someone who we now know actually very well that sleep is restorative to the immune system. So someone who's not getting sleep is really immunocompromised, and they have frequent infections. They're always out of school. He had mono. He had sinus infections. He had ear infections over and over again. Very bad reflux, and actually neck pain. On further questioning of him, he had some headaches, but more so his legs and feet would jerk frequently at night when he was sleeping. He had numbness and tingling in his hands. He had urinary hesitancy. This is a teenage boy. This is not an old man with, hypertrophic prostate or anything. This is a 15-year-old boy, and when he stood to urinate, he had to actually physically push. It had come on so gradually that he thought that was normal. And I'll tell you, most of the time, this is a symptom that the parents will know nothing about because the kid doesn't really realize it's abnormal and he hasn't told his parents and they're not in there with him. Anyway, his parents had noticed that when he had growth spurts, this got worse. So what I want you to notice is we have symptoms involving the legs and feet, the bladder, the neck, and all the way up to the brainstem as far as sleep apnea. And this is how he sleeps. His mother gave me this picture. He slept with his neck extended to shorten the traction on his spinal cord. I mean, he's not consciously doing it, but that's what his body was essentially doing, trying to compensate for this yank all the way down his spinal canal that was actually impinging everything and causing everything. On exam, he was very hyperreflexic. He had a Hoffman sign, which is another sign of hyperreflexia. And then, of course, the sleep study was terrible. He was desaturating 100 times, and he was getting no REM sleep at all, which is the restorative sleep. And this was his MRI. Of course, read normal, but more to the front here, more to the back here, and then this thickened fatty phylum pulled to the back. Now, this is his MRI on the right. This is a normal MRI. This is a 12-year-old boy who came to see me for back pain after playing basketball or something like that. And I kept it because it was a really good example of normal. I think that's very useful when we start thinking about what's normal and abnormal. Notice the spinal cord comes straight down the center of the canal, and then the nerves just come off and go on their way, as opposed to this kind of tension picture. If you look at the cross sections, you see the normal conus is right there in the center with the nerves coming off all around versus this thickened phylum pulled to the back. And at surgery, this is what I found. A tight phylum yanked this way with the nerves much more relaxed around it. So I untethered him and everything went away. No more sleep apnea, no more fatigue, no more illness. Legs stopped jumping around at night. He graduated with a 4.0 GPA for his last 2 years of high school and went to college and did well. Okay. So this next one is a 6-year-old. He presented with urinary and fecal incontinence 3 to 4 times a day. Now, 6 years old, right? That's getting a little old, and it's actually a problem because it's time for him to go to regular school. And he can't be in regular school if he's not potty trained. And from their standpoint, he's not potty trained. We see the abnormal angle of the spinal cord with the thickened phylum here, and in cross section, the big fat thickened phylum. Now, a word about this angle. MRI shows you the angle, but it doesn't show you necessarily what is tethering the cord. And in these cases, I usually find fine adhesions in here tethering the cord, but that's not what will show up. But you know they're there because something has to be holding it there, yanking it there, unless you see something like, a tumor, or it's stuck to a bony spicule, or a cyst. Then a fatty phylum is less elastic because fat is less elastic than filar tissue. So it doesn't stretch and grow with the patient as they grow. So back to this little boy, all of his milestones were normal. And I untethered him, and all of his urinary and fecal incontinence resolved, completely resolved within 2 months of untethering. Okay. So you notice a very subtle, bright signal here on this one. This was a 14-year-old girl who had had about 4 months of back pain. And they thought that it was from softball practice. But then she got this MRI, and not only is the spinal cord pulled very straight, she actually had a lipoma here. And this was a dorsal lipoma. So again, anything that is, stuck to the spinal cord, by definition, it's tethered. If we see this in a 35-year-old person who really doesn't have many symptoms, is not growing anymore, then we might not do anything. We might just follow it. But that doesn't mean it's not tethered. And sometimes on radiology reports, I'll see the words a non-tethering lipoma of the spinal cord, or an incidental finding of, some of my favorite words, you could tell. It is tethered. Now, you make a clinical decision on whether or not to do something about it, but it's tethered. Okay, so this 13-month-old girl, kind of the same thing. She had just a deviated gluteal cleft. So the gluteal cleft can be, straight, or it can be what we call kind of bifid like this, but it shouldn't be like this. So if it's asymmetric, then that's suggestive of a tethered spinal cord. And again, in a baby, you don't need anything else. You don't need a whole lot of signs of tethered cord in a subtle case to go ahead and get the MRI and, and send the patient to be evaluated. A baby is not going to necessarily show neurogenic bowel and bladder for 4 years until, he's 4 years old and you're having difficulty potty training. I mean, if the diaper is always wet or always soiled, never dry, then that's kind of suggestive of neurogenic bowel or bladder. But to wait in a baby for sort of more signs than some of these signs we see on the back, and maybe abnormalities of the feet and things like that, you're letting the child grow and getting more and more traction on the spinal cord. So I try to avoid that. And this was her case. And there was her fat phylum right there. Then I'm untethering from the spinal cord. This 6-month-old had a midline lumbar hemangioma and a deviated gluteal cleft. And the other thing you notice, a filar cyst. He had a cyst in the phylum, which again, anything in the phylum that is not just the phylum, it's tethered. Other views also show the syrinx. And typically, and this has been reported many times, a syrinx is most commonly caused by a Chiari malformation or a tumor in the spinal cord, but it can also be caused by a tethered cord. And when we release the tethered cord, a lot of the time the syrinx resolves. And this is what that looked like intraoperatively, the cyst and the fatty phylum there. Okay, let's see. So they can get older, right? 17 years old, almost fully grown. And she didn't really have a history of back pain, leg pain, hadn't had frequent urinary tract infections, which is a lot of the time what the teenagers will present with, either bowel and bladder symptoms or scoliosis, a progressive scoliosis. She was fine, but then she was having headaches and she underwent a spinal tap and couldn't move her legs because her tethered cord that nobody knew she had gotten poked. She did recover all of her function, and her leg strength recovered, and we went ahead and untethered her cord. This little boy presented with, he was about 11 years old, and he presented with a subtle scoliosis. Now, scoliosis in a young boy is extremely unusual. Teenage girls can get idiopathic scoliosis, just for no reason. Maybe it runs in the family. Typically, the orthopedic surgeons will still get an MRI and try to make sure that it's a relatively innocent scoliosis. But if you see a scoliosis in a male, and particularly a young boy, that really should, sound the alarm that there's something going on with the neuroaxis. So he had the scoliosis, we got the MRI, he had a subtle tethered cord, and after spinal cord untethering, his spine straightened. So he never needed to have bracing or, scoliosis surgery or anything like that. It's an example of high arches that they can have. And actually, a little bit subtle, but notice that the left calf is bigger than the right. And she had this tethered cord, as well as the small syrinx. And there's her tight phylum, yanked like a guitar string. And now released by me, gone. Okay, these are more kind of pictures. As you can see, you get the pattern, and we have been able to show, actually, some of my research is directed towards this. Um, the dorsal positioning of the spinal cord is independently a sign of a tether cord. And when I have explored these patients, I have never just opened and found nothing wrong. That always indicates, together with symptoms and signs, always indicates a tethered spinal cord. So it does not have to be low lying. And that's the part that has become controversial. A low-lying conus, yes, is a sign of a tethered cord in someone that's symptomatic. But it doesn't have to be. It can be stuck anywhere. It can be stuck higher and still be tethered. And as my friend Petra Kling has pointed out in her research, you still see the same physiologic changes in the spinal cord tissue, the same damage from the repeated stretch and yank on the cord, even when the conus is not low-lying. Okay. There's another one in which the conus was as thick as spinal cord. And so here was the end of the spinal cord there, and here's where I've cut it. So we divide it, we do these cases with monitoring. And when we stimulate down to the lowest levels, S3, 4, and we are no longer stimulating the tissue, then that becomes the phylum and no longer, eloquent spinal cord. And that's where we divide it. And I personally like to take a length of it so that it can't just stick back together. Okay, so now after everything I've told you, here we've got a straight spinal cord. It's kind of stuck to the back here. And you see it's a thickened phylum It's stuck to the back. This is actually a child who was in a study for nerve rerouting to restore continence, bladder continence for patients with spina bifida. And so she had been closed at birth, and we opened her up to do the nerve rerouting, not to do a spinal cord untethering. But in that trial, if we opened them up and they were tethered, we would go ahead and untether them and then do the nerve rerouting procedure. She was not tethered at surgery. So she did not have back pain, didn't have leg pain. Her bowel and bladder function were at the baseline that they'd always been all her life. She wasn't tethered. So the bottom line is, even if the MRI is suggestive, it's a clinical diagnosis. And in my opinion, MRI tells me more where it's tethered than if it's tethered. I've already decided from the history and the examination that whether or not the person is most likely tethered, and then I get the MRI to see kind of where. Now, if the MRI looks completely normal, like that 12-year-old boy example of normal I showed, then I wouldn't operate. But again, when people have symptoms and signs, there is something wrong, and you just have to look and you find it. So that's what I have for tonight. Are there any questions?
Thank you so much, Dr. Gilmer. We have tons of questions. Yes. Thank you. Um, if you wanted to stop sharing, you could, or if you wanted to leave it on whatever slide, is
I
your
can stop.
your favorite. But here we go. There we go. Put you front and center. Yeah.
Okay.
So we took questions two ways. So when people registered, so we have some preset questions, and then our Q&A is live. Again, our chat is disabled. Apologies on that. Did not
Okay.
know that setting was turned off, but everyone can use the Q&A function, and upvoting is also turned on. So if you see a question you like, give it a thumbs up and it'll rise to the top. And it sounds like we're going to
Oh,
try to get through as many of these as we can.
okay.
I wanted to start with one that a couple people had, and just because it was the last thing you mentioned, which is a syrinx. So you mentioned that a syrinx can resolve on its own post-release. If it doesn't release on its own, let's say 5 years post-release, what does this say to you? What else to look for? And then another question that someone had related to syrinx is the presence of a small syrinx mean that the child has to be operated on, or can we follow up for symptoms? So it's kind of a dual question about syrinxes, but if you want to talk a little bit more about that.
Okay. So I'll talk just about syrinxes as related to tethered cord. And a lot of the time they go away because when you cut the phylum, you cut the end of the central canal, which is communicating with that syrinx, and it drains out. But they don't always go away. And what you have to bear in mind is that a syrinx is a sign of spinal cord damage. So this may have just gone on too long. It may have gone on since, the child was in utero. And so it's just not going to go away or get smaller, but the goal is to keep it from worsening. And it's a sign, it should be thought of as a sign of stress to the spinal cord. So when you see that, you do want to relieve whatever is stressing the cord. Now, if a child has a very small syrinx, that might be more of a persistent central canal, which, when we are in fetal life, everyone has what would look like a small syrinx, which is a central canal going up the center of the spinal cord. And then over the time between, in utero and first, month or two of life, it closes off. But in some people, it doesn't. So if it's that, then we don't do anything. I am not a big fan of watching syrinxes. If that is literally the only symptom someone has, well, so then if I saw a patient who said, I don't, or my child has no other symptoms other than that, then I would say, but they got an MRI for some reason to find it. And then it would come out, well, they have some back pain, they have some, funny feelings in the legs or feet, they were walking funny, running funny, something.
So it sounds like a syrinx points to a bigger part of the story for you.
In my opinion. In my opinion, I know there are people who watch them. Yeah, but the other problem is when it's a sign of ongoing damage or stress to the spinal cord, things can happen that aren't always readily reversible, like the foot deformities, the foot turning in, uh, loss of sensation in the feet with subsequent pressure ulcers, which can turn into just a disaster, a nightmare, right? I'm sure some of you have either seen that or heard of that. So, yeah, I like to take care of it.
Yeah. We had a specific, and we're just going to kind of jump around here, but there was a specific question about case one, the case studies that you mentioned, which were very helpful. I took a lot of notes on that. The question is, was any seizure activity or abnormal brain activity noted in conjunction with his sleep apnea?
No, no, he didn't have seizures. No, this was one of those kids that had been to many, many doctors and had been extensively worked up and, was almost teetering on the verge of being called psychiatric or, whatever. Just because, when it's the central nervous system, the findings can be very disparate. They can seem unrelated, you know, and you just have to try to put it together.
Okay. Sort of goes along with that, some other symptoms, which you touched on a little bit. Can you talk a little bit more about the connection between allergies and hives in kids in tethered cord? One of your case studies mentioned an increase in allergies.
Um, One of the cases I showed,
Oh, maybe, you know what? Maybe I got that conflated. But I guess the question is, have you seen a connection between children with increased environmental or household allergies and tethered cord? Is there a connection in your experience?
So what I would say is another area of my research is we have found a pretty convincing link between connective tissue disorder and increased incidence of tethered cord. Connective tissue disorder, as you probably know, is also related to MCAS, mast cell activation syndrome or disorder. And so that's what I would attribute that to.
So that increased allergy response would be in connection with the MCAS.
Yes.
My understanding as well. All right. We have another one from attendees today. It says, let's see. This is a sweet one. I have an 8-year-old baseball child with tethered cord. He is growing currently. We kind of talked about this, the growth spurt. He just started peeing his pants during games when he's running. He does not when he's not playing baseball. Can the cord pulling while running be the issue?
Yes. So with problems like this, you can modify activity to avoid, problems. I mean, my first thought would be, okay, he's got to void before every game. Kids at that age don't want to stop what they're doing to go to the bathroom. They think they're going to miss something or whatever. And then, even kids without a tether cord can have an accident for that reason. But on the other hand, I don't want a kid to have a restricted life, to feel like they've got to always be, altering their activity. I want them to just live and run and play baseball and do all those things. So.
Be as active as they can, it sounds like.
Be as active as they can. And so if untethering takes that, I know it's scary. I know operating on a child's spinal cord it's a scary thing to imagine. And again, the symptoms come along so gradually, you kind of get used to it. And, other specialties can kind of sometimes encourage us to treat each symptom individually. Urology is managing this, and, physical medicine and rehab has them in new braces or new splints or something. And, everybody's got their part, and you can get away from fixing it, or now it's time to fix it, or now it's time to see if maybe it has retethered. And that's why everything's going out of control.
Funny that you mentioned retether. We got a lot of upvotes on questions about retether, and it's one of our most common questions that we get in webinars. Everyone wants to know why. What are your feelings? How do you prevent it? What do you look for? So, yeah, can you please talk a little bit more about, again, retethering in your experience? And then the specific question mentioned retethering after initial surgery for spinal lipoma. So basically, a lipoma is what this is asking, but I think across the board.
Mhm.
Yeah.
Okay, good, good. And that's a great question because I was going to say different types of tethered cord have different risks of retether. And the spinal cord lipomas have the highest risk because the lipomas are benign and they're slow growing. But the goal of surgery for them is to disconnect the spinal cord from the lipoma, not to do a complete resection of the lipoma. We get as much of it as we can, but the primary goal is to disconnect it. So there will always be a little bit left, heading way down towards the coccyx, as well as going usually up into the spinal cord. And now I'm more talking about a transitional spinal cord lipoma. So they can grow back, and then they can tether. So we typically see them more uh, symptomatic at growth spurts. We are, as a field of pediatric neurosurgery, getting away from really repeat and repeat and repeat untetherings. Um, the literature does show that we can help with back pain and we can restore deficits that have occurred recently. So if somebody lost strength in a leg over the last 6 months, we can get that back. We can't get back strength someone's never had. If they normally catheterize 4 times a day, and they're dry between caths, and then they're suddenly leaking between caths. We can reverse that if it hasn't been going on for too long. But yeah, if typically, I think most people will, do an untethering once, they'll do a second one. For 3 or more, we're starting to look at vertebral column shortening. But that is, no center has done more than 10 or 15 of those anywhere. Our orthopedic surgeon colleagues have done it for other reasons. And so we work together with them um, and their, experience. And of course, we're experienced with tethered cord. So that's something that's kind of on the horizon.
Are you seeing more patients go towards the spinal column shortening, the vertebral shortening surgery as a solution?
No, I'm seeing them come to me for a second opinion because someone else suggested it. It's new. This is the new thing, but it's been mentioned, it's been talked about and presented at the last couple of pediatric neurosurgery meetings I've been to.
Yeah, it definitely is controversial, let's say.
It's
Um,
controversial, but sometimes you do have to. So I can tell you this, the short-term results, a year or less follow-up, have not shown more complications than traditional untethering,
Mhm.
repeat untethering, and they have not required another surgery. Now, 1 year follow-up is short. Most people are not retethering within a year. Some do, but most don't. So, the jury's out on long-term how well they will do. But I don't think anybody would argue that that would be worth trying rather than doing somebody's sixth or seventh spinal cord untethering.
That makes sense to me. We have a lot more questions and we're getting close to the end of our time. So I'm going to try to get, there's one question that has been asked a few times very patiently, and I'm going to do my best at trying to pronounce this. Is there a connection between rhabdomyolysis?
Rhabdomyolysis.
Rhabdomyolysis, thank you so much. I'm very bad at that.
Sure.
And tethered cord. Are you familiar with that? And can you speak a little bit about that?
So rhabdomyolysis refers to breakdown of muscle. typically from someone being, found down for a long time, someone who laid for whatever reason, fell down the stairs, hit their head, and kind of laid there for hours and hours, and or, some kind of horrible situation like that. And then the patient comes into the hospital, the muscle has broken down, and it's generally caused kidney failure a lot of the time. Um, hope, sometimes temporary, but it's pretty horrific. Offhand, I don't know of a connection between that and tethered cord.
Yeah, and maybe not. This first one was just, I think, like you mentioned, people are making connections between maybe some other comorbidities or some other rare
Yeah,
presentations. And this is what
yeah,
we're talking about today. What's tethered cord, what's not tethered cord. So it's still very relevant. We have one from Heidi too, and then we'll have to start to wrap for the night, unless there's anything that you want to answer, or you wanted to follow up on. Absolutely. But Heidi says we have two boys with tethered cord, and we're fortunate to have you as the surgeon for one of them. So maybe you know Heidi. Both have now been diagnosed with urachal remnants, one of which was tethered to his small intestine. How common is that? And then she says, are there any other tethers or other conditions we should look for related to remaining symptoms of neural tension, fatigue, nausea, etc.? So big question, but I think it covers a lot. So
yeah.
yeah.
Wow, I would say wow. No, urachal remnants are rare. That's extremely rare. Um, but it has been described. What you have to remember as far as tethered cord is this is a secondary neurulation defect. So everything that was developing around the same time can have abnormalities. So that's why we see spina bifida and vertebral body abnormalities with tethered cord. That's why we can see bowel and bladder, a horseshoe kidney, um, a single kidney. That's why we can see, these sorts of tracts coming and, muscle defects and all of those things. And then the urachal remnants are kind of part of that. Anything that was forming at the time has endured the same stress that led to all of this.
Thank you so
So,
much. Yeah, go ahead.
oh, sure. No, just say, I think as far as looking for anything else,
Mhm.
I think and chronic fatigue and those things, I think those are comorbidities of connective tissue disorder. And I think that's really going to be the key as far as relating all of these problems.
Yeah, thank you. Thank you so much for explaining so many like complex concepts to us. I know this hour like goes by so quickly. The connections that you've made between, I mean, I just wrote about a bunch of things. I mean, between sleep quality, but between, why the fatty phylum is the problem,
Mhm.
validating the incidental finding as something that, more clinicians don't understand about TC. Like, I think this has been really normalizing for a lot of people, myself included. So
Good.
I want to thank you so much for your time and sharing with our community. Want to try to end on time here. I want to very quickly just thank obviously Rebecca Smith here and everyone who supports our programs. Again, the Tethered Cord Support Alliance is the first and only 501c nonprofit dedicated to improving the lives of people with tethered cord syndrome. Our organization is 100% volunteer staff. So if you're interested in sponsoring our events, something like this, please get in touch with us at hello@tetheredcord. I'll put the information in the chat. If you'd like to support the work we're doing, which includes free programs like the one you're at right now, you can set up a one-time monthly or yearly donation via PayPal. That is also in the chat. So we appreciate everyone's attendance today. We had amazing questions. If we did not get to your question today, keep showing up to our webinars, keep submitting it. And, stay tuned on our website as we build those resources. Some of that information that you're seeking will be there as we work with clinicians like Dr. Gilmer to get that stuff on paper and out to you. This recording will be available on our website. Give us about 48 hours to encode it and everything. And if you attended, you should get a link with that. Yeah, I think we can wrap the night. Wave to me if I'm missing anything, Rebecca, but I think we're good. Okay, lovely. And thank you so much, Dr. Gilmer, again, for your time. This is so valuable. And come back anytime and talk to us.
Thank you. I love to talk about tethered cord. Thank
We
you very much.
would love that. All right, everyone. Have a good night. Take care.
Good night.